ስለዚህ እሺ እንዴት አመሻችሁ በድጋሚ this is part 3 of our surgical short discussion shorts ብሎታል ብሩኬ I think it is a good naming how was the day happy Saturday በማውራት አትታሙም it was great and productive ብሩክ ዘን እግዚአብሔር ይመስገን ዳክታንስ በተለይ አሜን አሜን እግዚአብሔር ይመስገን እንግዲህ በሰላም አምሽታችኋል ብዬ ተስፋ አረጋለሁ እኔም እንግዲህ ወደ እኩለ ቀን እየተጠጋ ነው it's around 11:39 a.m. here okay so I am happy that you guys are able to join us again so we'll continue our discussion I hope you benefited somehow from the previous discussions so we'll continue the same thing and like I said last time I would be very happy if you can participate you can unmute yourself and start talking anytime you are welcome to do that or you can continue texting whichever works for you I would be happy if I can hear your voice as well I mean አለበለዚያ እኔ ማያችሁ እናንተ የምታዩኝ እኔ ማላያችሁ የሚለው ይመጣል okay let's continue so who knows this structure this x-ray which part of the body is imaged and what is this structure down here and what's going on here you know if you respond fast we can cover a lot of topics and slides faster because like that would tell me you know it yes excellent Brooks and tube abdominal x-ray that's excellent you are right so we here we are looking I mean part of the chest you can be I say the chest because I see the rib vertebral column is right here and this is the abdominal cavity and you see part of the bowel here the small bowel and of course this is a T-tube so it's called a T-tube because it's a tube and it's in a form of T and T-tube who knows the purpose of inserting or putting a T-tube in a patient why do we need to put a T-tube so it's it all I mean all this slide is good because it combines the x-ray it combines the tube itself and it combines the patient and what is happening in the patient you see something being drained right so what's coming out is something which is greenish yellowish to greenish kind of fluid for drainage when we want to prevent skin contact what do you mean Bethlehem can you elaborate oh post-CBD exploration to prevent leak excellent yeah so this is the main reason so Brooke excellent post-CBD exploration to prevent leak so those people who are presenting to you obstructive jaundice and then if you find out that the obstructive jaundice is as a result of CBD stone or common bile duct stone then you know the type of surgery we do is called CBD exploration we explore at the time of surgery we open the CBD or the common bile duct we try to see if there are any stones we evacuate the stones if they are existing and then we will try to put a T-tube for some time and that facilitates you know the drainage of bile and at the same time you try to prevent leak because like you know this CBD is a small tubular structure you repair it and after repair there could be a leak because like you know it's a tubular structure and bile flows through that tubular structure so it has to be watertight right so it has to be watertight your repair should be watertight but it may not be until healing happens there could be some leak bile leak so if you allow bile leak what happens is bile peritonitis. First, at the beginning, it could be just a chemical inflammation. So we call it chemical peritonitis, bile peritonitis. And if there is a contamination with bacteria, and eventually this chemical peritonitis will be followed by bacterial peritonitis. So in order to prevent leakage and allow healing to happen, then you can put this T-tube. So even if there are remnant stones downstream, and even if the CBD is not completely free of the obstruction because of some remaining stones, at least this T-tube would allow drainage of bile to the exterior. So that means even if, like, it is blocked, the CBD is blocked distally, there is at least some passage, and that relieves the patient from obstructive jaundice. Plus, you prevent leakage at the site of repair of the CBD. And number three, you facilitate healing of the CBD. And after the procedure is completed, maybe after a couple of days, you would go ahead and do some imaging called what? What kind of imaging do we do? What do we see here? So it facilitates healing, it drains the bile to the exterior like this, like you see here. And at the end of the day, after about a week or two, you do a contrast study, and it has a name. And you do the contrast study because you want to see if the CBD obstruction is already solved or not, okay? Cholangiography, we call it T-tube cholangiography. So we call it T-tube cholangiography because you are injecting the contrast through the T-tube. You inject the contrast and then you lock it, or you clamp it, and then you take an X-ray and you see the contrast agent opacifying the biliary tree. So that's why we call it T-tube cholangiography. You can see, dilated branches of the biliary tree proximal intrahepatic. It looks like, probably this is the right hepatic, left hepatic, probably this is the common bile duct. And you see also the contrast going downstairs, downstream. So you can see the contrast coming. Is it patent or not? Is the CBD patent or not, guys? Yes or no? Quick answer. Whether you are in the library or at home or in a hotel or in a palace, you can type, right? Yeah, the answer, that's what I expected, Bethlehem. Thank you. Yes, it is, because we do see the contrast coming into the parts of the small bowel, right? So yeah, the CBD drains to which part of the gut? Anatomic revision. CBD drains to the second part of the duodenum. Excellent. So now you can see part of the duodenum, the jejunum. So at least it is patent. Then you are satisfied as a surgeon, then you can take it out, okay? You can take it out. So, I mean, healing has happened. It's almost 10 days, 15 days, and the passage is patent. So you can take out this T-tube and the patient is relieved from the obstruction. So why don't you do T-tube cholangiography maybe after a day or after 2 days? What do you think is the main reason why we don't do T-tube cholangiography immediately in the post-operative period? Why is that? So, I mean, one thing as a mentor or as your teacher, what I would try to encourage you guys is to participate. Always participate. It may be a wrong answer, it may be a right answer, maybe 50-50 kind of answer. That's fine. Just try, participate. That way, you will never forget. If you participate on something, you will never forget that discussion for the rest of your life. Okay, but if you sit idle, you will miss many things. So just force yourself, participate, type, speak up. I would be happy. I mean, like, if you get engaged, you will, motivate me more. Okay. It needs time for the inflammation to block it. Or you mean it needs time for the inflammation to settle so that there wouldn't be false negative. It will be false negative. It will rather be a false positive. You are trying to rule out whether there is an existing obstruction downstream or not, right? So if you do the T-tube cholangiography immediately, like you mentioned, Brooke, sometimes what happens is if there is an active inflammation, there will be edema. If there is edema, that tube is still narrowed, right? So the inflammation hasn't settled yet. There is some edema and all that narrows the lumen. So when you do the X-ray, you may think there is still a persistent obstruction downstream. That's one reason. You want the inflammation to settle, the edema to go away. Even if there is a narrowing, you wouldn't think, oh, could it be due to inflammation and obstruction? Due to edema? So that dilemma would be avoided if you wait 2 weeks or 10 days or 14 days and do the image. That's number one. Number two is when you do T-tube cholangiography, like I said, most of the time CBD exploration is done for CBD stone. And especially if there are multiple small stones, you may not evacuate the entire stone during the time of the surgery, right? So you may leave 1 or 2 stones downstream. You may not feel them, you may not get into them. It may be difficult to retrieve everything. So when you do the imaging within a day or two, sometimes, you know, air can be trapped because you have opened the CBD and air has already entered into the CBD. And then, like, you know, that air, when you take the X-ray, it will appear as if there is a filling defect, because if there is a stone, what you see in this imaging would be a filling defect. That filling defect is because part of the lumen is occupied by a solid organ, which is a stone. So when you do the imaging, so this contrast is not going to opacify the entire tube like this. Okay, so you may see some dark spot. We call that a filling defect. There is no filling defect here, but if there is a dark spot here, then you may think there is a stone sitting because there is a filling defect. It could also be an air which has been trapped during the time of surgery. So it confuses you. So the radiologist, even the surgeon, might think, could this be stone or could this be air trapped? They cannot tell, right? So that's going to be confusing. So if you wait for 10 days, 14 days, air which has been trapped during the surgery to stay like that or to stay that long is going to be less likely. So I'm sorry. So there wouldn't be that confusion ማለት ነው ባጭሩ. So that's very important to consider. So you wait until 10 days or 14 days. So this is tube cholangiography. We are satisfied here because the downstream is patent and the contrast is reaching into the gut. And you can see here bile is coming out. So somebody might ask you in a bedside examination to ask you without telling you, you cannot see this tube, whether it is T tube or not. This T segment is going to be folded like this, and it enters into the proximal side and the distal side of the CBD, and it will be straight like this after it enters into the CBD, okay? It will be like this. So this component is inside the CBD. One of them proximal, one of them going toward the duodenum, distal. It stays in the CBD, and this comes out of the patient's body. So what you can see is this segment and the connection, and you can see the content which is coming out through the tube. So I may ask you, what's going on? What is this tube? So you may say, maybe this is a T tube. And I will ask you, why do you think this is a T tube? Number one, bile is coming out. But you cannot be 100% certain whether this is a T tube or not. But it is a good guess. It could be. And number two, there is also another drainage tube you can see over here. And there is a bag. And this bag contains bile, right? So, I mean, somebody might ask you, what about this one? Okay, let's agree this is a T-tube. What about this one? And this tube is left around the area outside of the CBD, okay? Or around, just below the hepatic, the lower surface of the liver, around the area of the CBD, you have to leave another drainage tube. Reason being, like I said, your repair of the CBD may not be 100% watertight. Even if you have put a T-tube and the T-tube helps you to drain some of the bile, some bile will continue leaking, right? So just to the outside environment, just to the surrounding area. And that has to be collected and it has to be taken out of the patient's body. Reason being, we want to avoid chemical peritonitis, eventually bacterial peritonitis. So this is a tube which is kept outside of the CBD to collect whatever leakage happens at the site of the CBD repair. Okay, so and that's clear because bile is coming out. It's doing its purpose. Okay, so there are two separate tubes you can see here. So during exam, if somebody asks you, what is this? Just tell them what you think. You cannot be 100% certain because you don't see where this is. You can guess, but you cannot tell. You can guess where this is going, but you cannot be 100% certain. And your reasoning should be based on a logical guess or description. Okay, I think this is a tube because it is draining a bile. And I think this is a collection tube outside of the CBD around the area of the surgery because I see a bile coming out. And when do you remove abdominal drainage would be the other question. So this one I told you, once you confirm the CBD is patent, there is nothing, you can take it out, the T-tube after a couple of days. But this abdominal drainage, which one should come out first, the T-tube or this one? The abdominal drainage or the T-tube, which one comes out first? Brooke, excellent. The T-tube has to come out first. Excellent. Reason being, there is a hole. Inside a hole, you introduce this T-tube. Now you are pulling out the T-tube, and of course, you are going to leave some hole right there. So there will be a continuous leakage of bile after the T-tube is removed. But the hope is, since the downstream is patent, what we hope is through time, bile, most of the bowel, bulk of the bile goes down to the duodenum, there will be eventually some leakage, and that leakage of bile will be taken care of by this abdominal drainage. Okay, so the titube may come out maybe 2 days earlier, 3 days earlier than this one. We keep this for some more days until we are satisfied there is no more biliary leakage. How do we know? We measure the output every day. So like, day one after the tube removal, the amount of drainage, if it was 300 ml, then by the second day it becomes 200 ml, third day it becomes 100 ml, and then fourth day it becomes 50 ml. Fifth day you wait for it, there is nothing coming out. Sixth day, nothing coming out. Then if you are certain that there is no more leakage, and then you are safe to take out this abdominal drainage. So simple principle, okay, simple principle, logical principle. So these kind of questions may follow following just a simple X-ray like this. I can give you this X-ray and I can ask you all these different things during your exam. It's not only for the exam. I told you last time, the main reason why I'm doing this or these sessions is mainly to help you understand basic principles in surgery, in internal medicine, gynecology, pediatrics, so that you become a better physician. Even though I'm not around, you know what to do. Even though the surgeon is not around, you know what to do. If you are in a district hospital, you know what to do. So that is the main reason, it's beyond the exam. So these kind of questions might arise following just a simple tube like this, or a simple chest X-ray like this, or following this one. Okay, sounds good? Great. So you can see here, so this is another T-tube. You can see, the contrast going down because I see the bowel here. You can see the branch because since you are injecting, the contrast can go up, can go down. Eventually it will go down. So that's also T-tube cholangiography. Okay. So, but nowadays, CBD stones are not managed with CBD exploration. In most places, I see many patients with CBD obstruction here. The way they are managed here is you do, what kind of procedure do you know? Which can avoid surgery for CBD stone? Can you tell me? Less invasive. ERCP, Mahalit, excellent. Yes, ERCP, not laparoscopic surgery. ERCP, you do endoscopic, retrograde, cholangio, pancreatography, you diagnose there are stones, and then you introduce something with a balloon, and then you retrieve the stones, you do sphincterotomy. So the sphincter of OD, you incise through the sphincter of OD, you make it patent, you make it wider, and then you retrieve the stones through ERCP. Yes, it's a very common procedure, by the way. Here, it's a very simple procedure. It's endoscopic procedure. You go down, you try to identify the sphincter of OD. It goes there. What was the hole called? Ampulla of water, right? So you try to identify the ampulla, you cut through the sphincter of OD, you remove all the stones, okay? And then you see the patterns. Since it is under laparoscopy, you will see when the stones are being retrieved, you can see the stones coming out. At the same time, you can see the patency and the bile clearly comes into the second part of the duodenum. You can visualize that with endoscopy, with ERCP. So these days, there is no need of, doing T2 cholangiography. There is no need of doing CPD exploration, of course, unless it is really challenging and there are other indications. Of course, laparoscopic cholecystectomy has to be completed because most of the time, even though stones can be formed de novo within the CBD, most of the stones in the common bile duct are originating from the gallbladder. So because of that, most of patients with CBD stone, they have also gallbladder stone, or they are diagnosed with cholelithiasis. So in order to cure the problem, you have to, go ahead and complete laparoscopic cholecystectomy. Laparoscopic cholecystectomy, ARCP would solve the matter. Okay, you can clearly see here, this one is, I think, a fluoroscopically done, so you can see a proximal segment, distal segment, so it's clear now, there is no distal obstruction. So this is T-tube cholangiography. The other one is, even if you want to do Open surgery, you can also do on-table cholangiography. So you do the X-ray after finishing, immediately after finishing your surgery, and you can see if there is any more obstruction, if the contrast is not trickling down to the second part of the duodenum, which you can see during the time of the surgery, then you go ahead and complete the procedure. You attempt more and more to remove if there is any remnant stone or something like that. Okay. All right. All right, all right. The other thing which can, give you an impression of the presence of a feeling defect could be a clot following the surgery. There could be some bleeding. That bleeding might clot, and the clot might obstruct. And then that clot also, when you do the contrast, it could appear as if there is a feeling defect. It can confuse you with a stone. So in order to avoid that confusion, especially in resource limited setups like that of ours, we do still practice. I think we do still practice. As far as I was in Black Lines, I mean, I was not directly doing this kind of surgeries, but we used to practice during my residencies. I mean, CBD exploration was a very common procedure which you used to do under general surgery. All right, so that's it. Any question? Before we go ahead and discuss your friend here, any question? Questions? Question? All right. Nope. Okay. ብሩክ ወክለው ነው የላከው አይደል? ተናገርልን እባክህ ብለው። All right, there is no question. That means it's clear, right? I will assume that it's clear. All right, good. So what is this? I said your friend because, like, you guys are familiar with this, right? What is that? Yeah, Foley catheter. Excellent, excellent, excellent. So it's a catheter. Excellent. You said Foley catheter because there are also other different forms of catheter. There is a metallic catheter. There are different catheters. So this is typically described as a Foley catheter. So what kind of Foley catheter, Bethlehem? Andualem and Bethlehem, I appreciate you very much because you guys are participating. Yes, excellent, Tamaskan. Here we go. We have a third person. Two-way. Yes, two-way it's called two-way because there are two ways, one or two. All right, that's it. As simple as that. What holds a Foley catheter in place after a patient is catheterized? What keeps it in place, by the way? How does it stay within the bladder? These surgeons and other clinicians are magicians sometimes, right? So is it by magic or what? What keeps it in place? Does anybody know? Excellent. We inflate it. What do you inflate? Inflating fluid. What is inflated? The inflated balloon, perhaps. Excellent. So there is a balloon which can be inflated. Where is the balloon? The balloon. The balloon is located right here. It is right. All right. So which port is used to inflate the balloon? Yeah, in-person discussion is much better because I can ask you questions and you to participate. So which one? Say something. Which port? This one with some writing on it, or the orange one? Say orange or the other one. Which one do you use to inflate the balloon, guys? These are practical things, and you may be embarrassed in the emergency department if you don't know this. So you have to know this, okay? Orange, excellent, you know that. So this is the port through which you inject air or some saline or water, whatever. So we prefer some fluid like saline or something like that, distilled water. Mainly because the water stays within the balloon. The air sometimes through time when you pull it, whatever, some leak may happen and it may slip, but it doesn't slip if you have deflated very well, inflated it very well. So this is the port through which you introduce the fluid or air to inflate the balloon right here, and the balloon keeps it in place. The balloon keeps it in place. So one of the complications of catheter insertion is urethral injury, especially in male, right? Reason being, if you inflate the balloon while the tip is within the urethra, then you are going to rupture the urethra and cause urethral injury. It's a common happening. You may see people coming with penile bleeding, urethral bleeding immediately following catheterization, and that happens because somebody has tried to inflate the balloon while this tip is within the urethra. So in order to avoid that potential complication, advance it up to the end. Advance it up to the end. So there is no way this tip would be within the urethra. For sure, you will be in the bladder. So some people, the common mistake is like, they introduce a catheter and they see urine coming and they think they are in the bladder. Of course, they are in the bladder, urine is coming out. But like, if they don't advance it, while you are trying to inflate, you may pull it a little bit backwards. And then when you inflate, you are inflating within the urethra, and then you cause urethral injury, urethral bleeding. People come with torrential bleeding sometimes, which is very difficult to stop. So I have seen many people coming with urethral bleeding as a result of complications related to catheterization. So advance it up to the end, up to here most of the time, and then inflate it. When you inflate, you avoid injury, okay? All right, so you see a two-way catheter here, you see a three-way catheter here, and this is what I was talking about. So here is a balloon. The balloon is at the tip, and there are two holes. You see the holes here? At the tip, there are holes. Those are the holes which are used to drain the urine, okay? They help you. You see better here. So there is a hole here. So through that hole, the urine comes through this tube and then it comes out this way. It doesn't come out this way. This is a port for inflation. This is a port for drainage. When it is a three-way, so the urine can come through this one and through this one. So why do you think this one has a three port? Why do we need the third port? So you now tell me the answer, okay? This one has three, this one has two. What is the basic difference between a two-way catheter and a three-way catheter? All right. All right, for irrigation, excellent. Cleansing, yeah, irrigation, very good. So most of the time we use this port, the larger one, probably for drainage, and we use this port to connect it with some like, saline. For example, if you want to do a continuous bladder irrigation, you can connect this port with an IV bag, full of saline, and then the saline would go with gravity through this one, goes in, comes out, irrigates the bladder, and then you just recollect that same fluid, you drain it through this one. Okay, so sometimes it can be used for irrigation, and then whatever you are irrigating comes out like this. Okay, so what conditions do you know which might require a continuous bladder irrigation? In what scenarios do you do bladder irrigation? PO, bladder outlet obstruction? No, you don't do irrigation in bladder outlet obstruction. It's already obstructed. The only thing you should do is like, if a patient comes with acute on chronic urinary retention, then, the immediate management would be to catheterize them and drain the urine. So you just simply drain. So there is no need for irrigation in bladder outlet obstruction. What clinical situation do you know which might, yes, transurethral resection of prostate. Yes, it requires continuous irrigation. And that's mainly because after you do the procedure, there is a tendency for bleeding. There is a tendency for clot formation. If that clot is retained, it's going to cause obstruction of the bladder, and then patient would present immediately after 6 hours of the surgery. Patient might be like, crying like here, oh my God, I'm dying, blah, blah. He is like, disturbing the entire ward. The nurses are freaking out. Then they will call you. Mr. So-and-so, Miss So-and-so, your patient who has been operated 6 hours ago, transurethral resection of prostate. Now his belly is swollen. He's crying for help. Then that's because of what? Because the clot is retained and the patient is not able to evacuate the fluid which you have used for irrigation, plus urine by itself is retained, bladder is distended. It's a very painful experience. Patient is shouting. So at that time, you have to come and try to irrigate the catheter. Don't remove the catheter. The urologist will hang you if you do that. So don't remove it. Just bring a 50 cc syringe, use a sterile saline, and then push with force with 50 cc syringe. That is in an attempt to dislodge any clotting which has blocked these holes. So then once you do that, some urine, some blood mixed urine start coming out. So the irrigation has to continue for some time. Excellent. After bladder cancer surgery, we call it TURBT, transurethral resection of bladder tumor, or TURP, transurethral resection of prostate. These are procedures which are associated with post-op bleeding, clot retention, and then urinary retention, a very painful experience. So in order to prevent that, immediately after the surgery, if you see them coming out of the OR, they come with some, irrigation fluid coming, accompanying them. So there will be a continuous bladder irrigation. All right. So anybody with gross hematuria might require, for any reason, bleeding bladder tumor leonichelal following transurethral resection of bladder tumor leonichelal following TURP leonichelal, or following whatever kind of bladder surgery leonichelal, like, prostatectomy, transvesical prostatectomy. There will be, the prostate bed would continue to ooze, and then that oozing may clot, and that clot might block the catheter, and that results in retention. So in order to avoid any bladder surgeries like transurethral, TURBT, TURP, transvesical prostatectomy, and others, you always use this continuous irrigation. And for that reason, you have to use a 3-way catheter. If you don't have a 3-way catheter in the country or in your institution, how do you solve that problem? We say the continuous irrigation is mandatory. So you cannot do irrigation as well as drainage within a 2-way catheter, right? That is a limitation, and that's why we need 3-way catheter. So how do you tackle that challenge if you don't have a 3-way catheter? Are you going to say no more to RP, no more to RBT? Or do we have other solution for that? You haven't been following the urologists. Now I know. Now I know. Medication, anticoagulation? No, Brooke. I'm glad I am also an internist. Otherwise, if I was like only a surgeon, I would have scolded you. You don't give anticoagulation. If you give anticoagulation immediately after surgery, are you trying to kill the patient, Brooke? This is immediate post-op period. And the problem comes because of bleeding. And you are giving the patient anticoagulation. That means you are aggravating the bleeding. You got the point? Excellent, Andualam. Yes. This is not Dr. Andualam, right? The urologist? It's a joke. So, all right. So you put a suprapubic. So one goes through the penis, penile urethra, wherever you introduce it into the bladder. And the other 2-way catheter will be introduced transvesically, right? Suprapubic catheter in a form of a suprapubic catheter. So through the suprapubic catheter, you connect the irrigation one. So if let's assume this is the suprapubic catheter, it's introduced into the bladder through the suprapubic region, then you irrigate through this one. So you introduce the saline through this one, it goes into the bladder, and this one, let's assume it's coming through the penis, so that will drain it, right? So you use two-way catheters, one suprapubic, the other one through the urethra. That way you tackle the shortcoming of having only 2-way catheters. All right? All right. So I want you to read about complications of catheterization. So I told you one, urethral injury is one of them. There are other complications, infection, whatever, many complications related to catheter, especially catheter-related urinary tract infection is something which has to be prevented. So when do you remove catheters? There are multiple indications. I can ask you indications. One of indications is post-op period. Like we said, TURP, transvesical prostatectomy, any urologic surgery, you can say or rectal surgeries, abdominal pelvic surgeries, you may need to catheterize gynecologic surgeries, cesarean section, wherever you may catheterize. All right, total abdominal hysterectomies and others like, maybe cervical cancer surgery, radical hysterectomies and others. During that procedure, you may catheterize the patient. Okay, there are many indications for catheterization related to surgery or in general, there are other indications like ICU patients to monitor, like, urine output, critical patients to monitor urine output, shock patients to monitor, like, the response of your resuscitation and all that. There are many indications. So read about indications of catheterization, read about complications related to catheterization. All right. What is this? What is going on here? Urine bag, right? So urine bag containing what? Urine. But sometimes I may challenge you, this is a bile, or I may say, I don't think so. It's like intra-abdominal. I may say this is ascites. How do you know whether this is a urine or an ascites? Little bit of sense of humor ያስፈልጋል. How do you know whether this is an ascitic fluid or a smell? Or what about the other tastes? Maybe taste, I mean, you taste it. No, don't taste. Yeah, smell can tell you. And also, simply you see where this is connected, right? So if it is like, connected to urethral catheter, definitely this is a urine. If it is connected to a drainage tube in the abdominal cavity, maybe that's an ascitic fluid or anything, right? So always look into where this bag is connected because, we are in a country where there is a resource limitation. So urine bag may be used for multiple purposes. The original purpose is to collect urine, but sometimes some people, due to scarcity, maybe they may connect it with an abdominal drainage tube. Then it's not a urine, rather it's an abdominal fluid coming out. You know what I mean? So sometimes people may modify the purpose. That's why I asked you what is it containing? I mean, it's clear it's urine, but like, the main purpose is urine. But sometimes, oh, you think this is urine? Oh, I will surprise you, man. Then you just open the belly and the drainage tube is just in the right upper quadrant. Boom. And you start panicking because you are in exam. You think you missed the question and then you start panicking and no, always be smart. This is a urine bag. It looks like a urine because I also smell something which looks like a urine. Sometimes you may not smell anything unless it's spilling outside. This is completely tight. It's not, if it is not leaking, you may not have that additional sense of smell. So always be smart. It looks like this is a urine bag. I know what it contains also looks like a urine based on color. But let me see. And then when you expose the patient, then you see it, it's a catheter, either in the suprapubic region or it's coming through the urethra, then boom, that's urine. Or if it is located, if it is attached to a tube, which is like in other segment of the belly, then it may be something else. You got my point? Because we used to like tricking people like this. Yeah. All right, another friend of ours. What is this? Anybody who wants to say something? Who wants to say something? ድምፁን ማሰማት የሚፈልግ ድምፁን ማሰማት የሚፈልግ anybody volunteering? All right, that's fine. What is this? Just you, boom, asfausan. I don't agree. Does everybody agree? NG-tube. NG-tube. I personally don't agree. It looks big for NG-tube, right? And unless you are putting it in an elephant nose. Does an elephant has a nose? I don't know. Drainage tube, Brooke, you are smart. Yes, it's and the next answer would be tube. Oh, what did I do? Shit. What do you see now, guys?
Slider ነው የሚታየው።
Okay, so what do you think is this? You didn't get it yet. Suction tube, no, Sava. I'm happy that you guys are trying. Suction tube, we have suction tube. I'll show you. Foley catheter. Ahmed, this is Foley catheter, man. This is Foley catheter. This is Foley catheter. I'm talking about this one. Endotracheal tube, Tamaskan. Anesthesia, people will kill you. I'm glad we are doing this because, like, now I know, there is some gap. Intra-abdominal drainage tube, Brooks-Neber, no tube for enema. So, okay, you are getting closer, TM. TM is getting closer, tube for enema. Rectal tube, as far as. Thank you so much, my friend. So this is the rectal tube, okay? So somebody said chest tube. I may say, okay, I'll give you a credit for that because of resource limitation, I have used rectal tube as a chest tube multiple times, many times, because we don't have the proper chest tube. We are obliged to use rectal tube. But I will tell you, I will show you what the basic difference is between a rectal tube or not. Number one, there are only 2 or 3 holes here in a rectal tube. Okay, I will show you a chest tube and you will compare it later. And number 2, if you see here, there is an open end. This is an open end. Okay, because like, when you put it into the rectum, then it evacuates fecal matter and feces, gas, right? So it has to be open. It shouldn't necessarily be closed. The purpose is drainage. Chest tube is also drainage, but when you introduce it at a get-go, the end has to be closed. I will show you what it means. It comes with a closed tip at one end. We cut that one after we have introduced and secured the chest tube, because when you introduce it, the patient will start breathing, and when the patient breathes, if you are using this like open-ended rectal tube as a chest tube, what happens is air gets sucked from the atmosphere into the pleural cavity. That we don't want to happen. So what we do is, when we do use rectal tube in place of a chest tube, what we use is we apply a clamp over here. We clamp it with an artery forceps right here to prevent the patient from sucking air from the atmosphere into the pleural cavity. So you can modify the purpose. You can use rectal tube in place of chest tube, but you have to clamp it when you introduce it, when you insert it. And the other thing is, for chest tube, we need multiple holes at the tip so that we can evacuate gas, we can evacuate blood, pus, whatever it is. So what we do is we create more holes. I will cut here, I will cut here, probably I will cut here, add a number of holes to it so that it will be effective drainage tube. All right, so but the rectal tube may have only 1, 2, or 3 maximum. All right, so that's the basic difference. So this is a rectal tube. So Somebody mentioned rectal tube for enema. You see how it is introduced into the rectum. You can see the patient is in the left lateral position. We call it left decubitus position with the hip flexed, knee flexed, and then you have introduced the rectal tube. That's it. And the tip is blunted. If you see a rectal tube, it's blunt. The tip is blunt. That is not the case in chest tube. This is blunt. Why is it blunt? Why shouldn't there be a hole at the tip? What is the reason there is no hole at the tip? The holes are sideways, right? To avoid perforation. Not perforation. I mean, like the gut has mucosa, right? So it catches the mucosa. Where if there was a hole, then this hole will catch into the mucosa, and then it would be very difficult to advance it. It wouldn't be gliding easily, right, into this tubular structure. So it can, yeah, let you avoid, laceration, perforation, whatever, but it makes life easier. You can easily glide it within this, like, rectal cavity where there is a lot of mucosal folds, so it can glide easily. So it has to be blunt. All right. So this is a rectal tube, a patient in left lateral position, like I said. So this is one of rectal tube insertion. When you become an intern, you will definitely have a couple of patients, because patients with. So indications for rectal tube use. Somebody says for enema, irrigation. What else? In what other scenario does require placement of rectal tube placement? Other indications for rectal tube. Deflate the bowel, right? So bowel obstruction. Which kind of bowel obstruction? As far as last time, I advised you guys to be very specific when you answer questions. Yeah, I know, deflate bowel obstruction, but there are different types of bowel obstruction, right? So can you manage jejunal obstruction or duodenal obstruction with the rectal tube? No. So don't give me the chance to ask you further questions. So just give me full answer. You get the full credit, we go forward, right? Large bowel obstruction. What kind of large bowel obstruction? Again, I'm going to challenge you. Will you manage cecal obstruction with the rectal tube? No. Would you manage hepatic flexure obstruction with rectal tube? No. Descending bowel. What is a descending bowel? Ascending, descending. Yes, there is descending, but I mean, even the descending colon is far, far away from your rectal tube. Your rectal tube is like maybe 10, 15 centimeter long, and it's not going to reach up to the level of the descending bowel. Ilioanal obstructions. Solomon, ilioanal. I don't think there is a condition called ilioanal obstruction. Rectosigmoid obstruction. So give me a specific answer. Yes, rectosigmoid obstruction, but what kind of rectosigmoid obstruction? I mean, cancer, for example, anal cancer, do you manage with rectal tube? Rectal cancer, can you manage with obstruction? I mean, with a rectal tube? No. Mechanical, no. Fecal incontinence, no. Excellent, Male, thank you so much. Excellent. Sigmoid volvulus. Okay, sigmoid volvulus. So sigmoid volvulus results in large bowel obstruction. You do X-ray, then the X-ray is typical. What is the typical X-ray appearance for sigmoid volvulus? I think part one, there is a sigmoid volvulus. I am sure I have discussed about intestinal obstructions and types of intestinal obstruction on part one, which we didn't discuss with you guys, but I've discussed it with the previous group. Coffee bean appearance, fatal and excellent. So you order a plain abdominal X-ray, typical coffee bean appearance, patient's belly is distended, vomiting, there is no vomiting, it's tympanic all over, and then the duration is short, patient came within 3 hours, it hasn't been a long duration. Abdominal examination, there is no tenderness or rebound tenderness. Digital rectal examination is in PT, rectal ampulla, there is no blood, nothing. And then vital signs are stable, patient is okay, other than having like abdominal distension and abdominal pain and failure to pass feces and flatus. So in that case, you can go ahead and try deflation, and omega sign is the other one, coffee bean or omega sign, JAF are excellent. So you can go ahead and simply manage them with the rectal tube deflation, but that is not the definitive treatment, okay? So in base centers, you may not even need to do rectal tube deflation because it's a blind procedure. Sometimes you may assume this is a volvulus. You may be surprised. It could be something else. Could it be cancer? Could it be something else? So in order to visualize everything, people do, sigmoidoscopic evaluation with deflation. So you can do simple sigmoidoscopy with deflation can be done if you have the access. You don't have access, even an intern or a medical student can do rectal tube deflation. It's a very common procedure, okay? So be careful. Don't be super excited to do the procedure and put the tube without protecting yourself, because sometimes, everything might splash you because it comes with pressure, with force. When it evacuates, it may splash you. So sometimes we were designing, we were trying to be creative by doing something. So at the end of the tube, we apply a disposable gauze, whatever this, not surgical gauze, I mean a glove, the disposable glove, we will attach it, we will tie it here at the end, at the just at the end, at the tip. So when it deflates it, whatever gas or fecal matter comes, it stays at least for some time, to a certain extent within that glove we have attached. So it's not going to splash your face or splash your clothes and all that. So be careful, okay? Don't be excited. All right. What about this one? What is this? I mean, these are fancy things. I mean, theoretically, ideally, these things should be available. They may not be available in our setup, unfortunately, but they should be available. So what is that? Hmm? Drainage chamber for chest tube. Excellent. So this is a container, right? This is a container. This is a container which has to be attached to a chest tube. A chest tube. Yes. Yes. So you can see the number here. So it starts from 10, 20, 30, whatever. So you see what this one is attached to the chest tube, the actual chest tube, which is inserted into the pleural cavity. It drains the gas, it drains the blood, pus, whatever. So it comes into this chamber. So when this chamber fills, it will go this way, right? So 100 ml, this chamber can accommodate about 100 ml. Then it spills over, በዚህ በኩል ማለት spills over, it comes here, then 20, 200 ml, 900 ml, then when it is full up to here, it spills here, then 1000, whatever, up to 2 liters. Okay, so these 3 chambers, totally they can accommodate about 2 liters of whatever is coming out. Okay, it could be blood, it could be pus, it could be just pleural effusion, malignant or benign, whatever, paranymonic, whatever. So gas also would also get evacuated. All right, so that's very important. So this chamber is the underwater seal, and you can see the oscillation in the underwater seal chamber. What is underwater seal? Why does when I was talking about the urine bag, I was not talking about underwater seal mechanism, but for a chest tube, there should be an underwater seal mechanism. So what is meant by underwater seal? What does it mean? What does underwater seal means, and why do we need to have an underwater seal mechanism in a chest tube as compared to abdominal drainage bag or catheters, whatever, bladder drainage chamber for chest tube, so that air is not sucked into the chest. So I mean, this thing, whatever this tube, has to be immersed underwater, so that whatever air is in the atmosphere wouldn't be sucked in, right? Wouldn't be sucked in. So there should be, to avoid air entry from the atmosphere into the pleural cavity and have pressure difference. No, yeah, you don't want air to go there. That means iatrogenic pneumothorax, right? So you are preventing iatrogenic pneumothorax. So this tube here has to be underwater. It has to be to a certain extent, 2 centimeters, 3 centimeters. It has to be immersed underwater so that you prevent air gaining access from the atmosphere into the pleural cavity and resulting in iatrogenic pneumothorax. All right. So the same thing You can see blood, the blood is coming in, it's going there. So at least it has collected 100 and there is some spillover. I mean, this chamber has been full and then it has come to a certain extent. So every time you monitor the output, how much blood is coming out. So because like, immediately after trauma, if somebody has sustained trauma and develops hemothorax, and then you have to measure the output hour by hour, right? So and if it is very significant, then like, you have to call the chest surgeon. Massive hemothorax is an indication maybe for exploratory thoracotomy, emergency thoracotomy. So you have to monitor the output. And I will ask you, how many liters, how many ml of blood did the chest tube drain in the past 1 hour or 2 hours? And then if it is beyond a certain number, I would run to the hospital probably to consider doing emergency thoracotomy because it could be a massive hemothorax, significant bleeding. And that significant bleeding might be life-threatening if it continues like that. Okay, so the output has to be measured. That's why they have labeled this container with numbers so that we determine how much is coming out. When do you decide to remove a chest tube, guys? When should it come out? I asked you a question you didn't answer. When do you remove a catheter? That was question number one. Answer that one, and then you will tell me when do you remove a chest drain. And then question number three would be when do you remove an abdominal drain? Go ahead, answer. I'm waiting and taking a break. All right, all right. Symptoms relieved, yes. But the fact that symptom is relieved is not an indication to take a chest tube. If there was 2 liters and if I evacuate 1 liter, symptom will improve. Then you don't jump and remove the chest tube. All right, Malik, Mer, who is Mer? Symptom relieved, Alomano. Who said symptoms relieved? Let me see. Let me see who said. Mer said symptom relieved. So like I said, if there was 2 liters of blood pass, for example, patient is seriously symptomatic, I remove 1 liter, then definitely there will be a significant improvement in symptom and you don't take it out. Still there is 1 liter remaining, okay? So don't jump on imaging. So Mer was in the right direction. Symptomatic improvement is one of the things we look into. So you evaluate the patient. Are the symptoms relieved? Number one, that's subjective complaint. So you have to do your SOAP assessment, SOAP. So what are the subjective complaints of a patient? The patient was in significant distress, now no distress, or the symptom is completely gone. Excellent. And then what is your objective assessment? So you assess the vital signs, general appearance. Day one, patient might have been, breathing, labored, use of respiratory accessory muscles and all that. That's no more there. Vital signs were deranged. Patient was tachypneic, tachycardic. Right now, there is no tachycardia, there is no tachypnea. Patient is really comfortable. Day one, patient was really breathing fast and labored in distress. Now, patient is like, sitting on a bench, reading a newsletter or chatting with somebody. It's improvement. You go into the patient room, you watch, inspect the patient. The moment you walk into your patient room, watch the patient and you get a lot of information because you are comparing 2 different days. Day one, patient was gasping. Day two, patient is chatting. That's improvement, right? That's a green sign, right? So then you assess the vitals, you do the exam and examination. Day one, there was no air entry. Right now, day 10, there is very good comparable air entry in both lungs. Boom, very good. And then you can say, okay, let me do, I think everything seems fine. Symptomatic relief, everything, patient is stable, vitals are okay, good air entry. I think the lung is expanded, and I think the output is good. The air entry is good and all that, there is improvement. Then you can ask somebody, the nurses maybe, how much was the drainage? Then they will tell you, nothing, doctor, so-and-so. There was no drainage. For how many days there was no drainage? Maybe for 2 days, they will tell you. So the drainage 3 days ago was about 50 ml. Since yesterday or since 2 days ago, there is no output, or it's less than 50 ml over 24 hours. Boom. Then the final confirmation is to send your patient or ask the radiology department to come with a portable X-ray and take a simple chest X-ray. When you see it completely expanded lungs, there is no fluid, there is no gas, completely expanded lungs, nothing remaining. Then you convince yourself symptomatically improved, objectively improved, air entry excellent, chest X-ray fully expanded lungs, output almost zero or less than 50 ml in 24 hours. And then you say, okay, go ahead, take this chest tube out, purpose is over. So you have to go through all these assessment steps before you jump and remove. It's a symptomatic improvement is not the only one. Or objectively, you are satisfied with the air entry and all that, but still you may miss something. So you want to confirm it with imaging. So you have to follow that step, okay? Multiple steps. So when somebody asks you during a exam, okay, when do you remove a chest tube? You have to answer the way I elaborate now. If you do that, for sure, I will give you an A, no doubt, above 90. All right, you get it? Good. Clamping and checking for 24 hours, that is not necessary. Why do you clamp it? There is no need. Especially, the danger with that one is, especially if the indication was pneumothorax, and you clamp it for 24 hours, you may kill your patient. How? If there was a continuous leak of air, you have clamped the chest tube, you have gone home, and this poor patient is gradually accumulating air and air and air, and there is no way that air can escape. The patient develops tension pneumothorax, you kill the patient. You kill the patient. All right, so there is no need. It's not a good practice to clamp. Just follow the practice I told you, the principles I told you. Subjective assessment, objective assessment, amount of drainage in 24 hours, chest X-ray. Everything is green, take it out. Don't even think. Don't wait for another 24 hours. Take it out. It has finished its purpose. All right. What about urinary catheter? When shall a Foley catheter come out? Very simple questions. Very simple questions. They appear simple, but you should know the real answer, right? So that's how you help the patient, and that's how you ace the exam. And that's the purpose of this presentation, all right? So simple questions, simple answers, but you should know them. If you don't know it, you don't know it, all right? So when do you remove a catheter? Very simple. Fast, 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 guys. We don't have time. You will be tired for post-op patients after. Okay, Bethlehem, I don't agree 100%. I'm sorry. When do you remove a catheter, guys? Excellent, Mer, depending on the indication. So once the indication is no more there, take it out. For example, a lady who is undergoing cesarean section, if you have noticed, if you have participated in cesarean section surgeries, one of the things they do is they catheterize the bladder before they make the incision, or while they are preparing the belly for a cesarean section, they catheterize the lady. Either they put a Foley catheter, or they can use simply a straight metallic catheter and evacuate the bladder. Why is the reason? Why do you think is the reason? What is the reason, guys? You have attached to gynecology, right? No? Yes or no? Have you guys gone through gynecology? Excellent, as far was excellent. So that they wouldn't damage the bladder, because the bladder is anatomically related to the uterus. It's sitting in front of it, anteriorly related to the uterus. So if the bladder was distended with urine and you make your incision, the phenolestan incision or the lower abdominal incision, and when you are trying to make the incision, you may damage the bladder. So you want to avoid, you want to deflate the bladder and get it out of your way so that you can do your transverse lower uterine incision to take out the baby, right? So in that case, the indication is just to make your life easier during the procedure. So does this lady need to be catheterized for a longer duration? No is the answer, because the indication was just like, to facilitate your surgery. As far as the patient doesn't develop acute urinary retention due to pain, you don't have to keep the catheter. You can take it out after a couple of hours, or you can take it immediately after the procedure is concluded. If you think the patient can urinate by yourself, if you manage her pain, she can urinate. There is no problem. Okay. All righty. That's it. If it is monitoring critical patient, you want to monitor the patient, the urine output, you want to assess whether resuscitation of a shock patient is working or not. You can catheterize them for a couple of hours and you monitor the urine output and everything. Patient is stable, hemodynamically okay. That crisis moment has gone. Then there is no need of catheterizing that patient. That patient can urinate by himself or by herself. Take it out. If it is a post-op one, for example, thoracic surgery, just for intraoperative monitoring, the anesthesia people would like to catheterize the patient because, like, the thoracotomy might be a little lung resection, decortications and all that. Sometimes there will be massive bleeding. And then, like, intraoperative resuscitation, its efficacy can be seen through the urine output. So the anesthetist or anesthesiologist might be interested to put a catheter for some time for intraoperative monitoring. And even that care might continue even in the ICU, but like, after the patient is stable, hemodynamically stable, there is no more bleeding, patient is out of the crisis mode, and then you can come and completely remove the catheter. You don't need it, because if you keep it indefinitely, you invite a trouble. And one of them is catheter associated urinary tract infection, CAUTI. It's a common discussion because, like most hospitals in the US, they would be evaluated based on the number of catheter-associated urinary tract infections. So if your catheter-associated urinary tract infection rate is very high, then you will be downgraded, okay? Your hospital would lose a lot, lose a lot. And the patients would also suffer a complication because it adds into their morbidity. It adds into their cost of their care. It adds into another misery, another antibiotics unnecessary, to treat that catheter-associated urinary tract infection. So that is it. Abdominal drainage. When do you remove an abdominal drainage? These are related stuff. That's why I'm asking you, okay? Maybe some of you guys might be interested to see my slide and leave. I don't know. I don't think so. I don't think you are here for that. But if I do that, it saves my life, it saves time, the same thing for you. But the problem with it is you don't gain much. That's why I'm going into a little, minor details and dissect everything, because I wouldn't do this again. So if I have to do it, I have to do it the way it should be done, right? So that's why I'm going to in depth to a certain topics, all right? I hope you like that. Do you like that? Yes or no? First, let's vote. Do you like this approach or not? Yes, Brooke. Of course, you are an organizer. You should like it, whether you like it or not. Yeah, Brooke. Yes. I think you benefit much this way than like, showing you the slides and, okay, this is catheter, blah, blah, No, we shouldn't do that. Okay. Only 3 people are listening or what? Yes or no? Do you like it this way, or shall I make it short and straightforward? Choose. Ahmad, yes. All right, good. So I think, good. Saba, yes. Mary, yes. Good. Good. So yeah, abdominal drainage. When do you take it out? And these kind of discussions, you wouldn't necessarily find them in textbooks. People would tell you through experience, Yeah, you may find them in textbooks, but you may not find them all the time. So, you get them in a bedside discussion, operating theater discussion or something like that, and it comes through experience, and you may not find them in textbooks. So I think it's a good opportunity for you guys. So when do you take out less than 25 ml for 2 days? Okay, Solomon, good try. Clear content, Brooke Zannaba. Clear content. Algapanyam, what we are trying to say. All right. We don't really depend on whether it is clear or not. We depend non-bilous, non-blood. clear content. I mean, let me say non-bilous, non-blood, right? So let me challenge you. Okay, Brooke, let me challenge you, because when we do transvesical prostatectomy, for example, urology, let's go back to urology. So when you do transvesical prostatectomy, earlier I told you, if you don't have a three-way catheter, I told you to put another catheter as a suprapubic catheter, right? That's number one. When you pull out the suprapubic catheter, there could be some leakage, right? So when that happens, just like the T-tube, you have to put a drainage tube around the bladder. So if there is a leakage at the site where there will definitely be a leakage after following transvesical prostatectomy, you repair the bladder, but the bladder is a container which contains urine fluid. So it's not going to be watertight, whatever you have done. So there will be leakage for some time, for some days until it heals. So when that happens, whatever urine leaks into the area around the bladder, that has to be drained using a catheter. So separate catheter, it's not a suprapubic catheter. Even if you use a three-way catheter, you have to put another drainage tube outside of the bladder in its vicinity. So whatever fluid is leaking will be taken care of that. Okay, so if you use two separate two-way catheters, one from below, one from above through the suprapubic region, you take out the suprapubic catheter and you keep that drainage tube outside until you confirm that there is no more leakage of urine out of the bladder. All right, so non-bilous, non-blood is not an answer, because urine may also be something which we are draining, right? So it's not the type, whatever. So abdominal drainage is removed when there is no more drainage, period. All right, so we don't use a certain number like, the chest tube drainage amount or something like that. Yeah, of course, when it comes down, if it is only 25 ml, 10 ml, 20 ml, I will take it out, because that amount of fluid will be taken care of by the body itself, by the peritoneal surface. It will get reabsorbed, right? So if the drainage is significantly as low as 50 ml, 25 ml, I wouldn't care. I will take it out. As far as it is as far as it is no pus, especially if it is pus, it will accumulate. Bacteria will replicate, and then the problem continues. So it has to be completely it should be as dry as possible, as low as possible. But this small amount, you have to take it out. And reason being, if you keep this drainage tube, be it a catheter, be it a chest tube, be it an abdominal drainage, pelvic drainage, whatever, if you keep them indefinitely, one of the danger is bacterial access into this sterile, what is supposed to be sterile environment, and then complication will appear. All right, so as far as the purpose is done, as far as the indication is over, for chest tube we use a certain number. For abdominal drainage, when it is dry, nothing is coming out, take it out. For catheter, when the indication is over, take it out. Okay, good. All righty, what is this, guys? Your friend here. All right. Just now you see the difference between the rectal tube and the chest tube, right? Clear difference. I mentioned it. At the end, it's closed. It is closed as compared to the rectal tube, which I am going to bring. This tip is open, whereas the chest tube, you can see here, is closed. The other end, 1, 2, 3, 4, 5, 6 holes as compared to this one, only 2 holes. Like I told you, if you are in a resource setup, you are forced to use this one. To make it closed, to make this end closed, clamp it. Number 2, to have more holes, create a hole using a scissor. Cut here, cut here, cut here, cut here, alternatively. Otherwise, if you cut here, and you cut here, you break it. So the next cut should be here. The next cut should be here. The next cut should be here. All right, you do that. And the other one, this one is blunt. That's a rectal tube and a chest tube. This one is open. You see, this is open. This is open, and multiple holes. All right. Boom. So this is the chest tube. And what is the purpose of this one? Why do you need this? What is this the purpose of this thing? The Zugize, if you have noticed, they come with a small plastic. They are covered within a small package, and they are part of the chest tube set. Okay. So why do you need this thing? This small thing here. Our friend here. Why do you need this? What is the purpose? To hold the tube. What do you mean by to hold the tube? Terminologies really matter, guys. Okay. To hold means holding like this. Holding means you hold like this, right? You hold something. So this doesn't hold. I mean, I don't know. Maybe it's a language. So it's okay. Maybe you are right. Maybe you got it. To connect. It's a connector. That's it. Connect to another chest tube, not another chest tube. You are connecting the chest tube because at the end of the day, once you introduce this one goes to the chest, right? This one goes into the pleural cavity. This end goes to the pleural cavity. This stays outside of the body. So you have to cut here, right? Once you introduce it, you cut it. Before you cut, what should you do? Before you cut this end, you can't drain because if this is locked, this is closed, so you cannot evacuate air, you cannot evacuate blood or pus, whatever, if it stays like this. But it doesn't stay like that. We will cut it here. We will cut this part. We will cut around here and make a hole. After making a hole, you use this one to connect it. You know, you see this diameter is smaller compared to this one. So this would fit into here. You will bring this one and fit it into here. And this one would be connected to another prolonging tube, which goes into the back or the collection system, right? So the tube which is connected to the chest battle comes and attaches here, and this one goes here. So this thing connects the chest tube with the chest battle. Okay, so before you cut, what should you do? I told you earlier when we discuss about using the rectal tube as a potential chest tube. I told you at that time. So what do you do before you cut? You clamp. Excellent. So before I cut, I clamp here. I clamp here, I cut here. Clamp it here and cut it over here. If you forget that and you cut it, patient is breathing. Patient develops iatrogenic pneumothorax. Okay, iatrogenic pneumothorax. So you clamp here, you cut here, you connect it. Once you connect it, you release your clamp. When you release your clamp, definitely there will be gush of air, gush of blood, gush of pus, gush of pleural effusion, whatever you are draining. All right, that's it. So here you can see the entire chest tube. So here is the entire chest tube. So why do you need to have these numbers, guys? Why do you need to have these numbers on a chest tube? You see one end is open, multiple holes. They are not clearly seen, but you can see one hole here, another hole. There are multiple holes. And one of the end, this one is the one which is going to be connected with the drainage battle to the chest battle. Yeah. So, and you have this number. Why do you need the numbering? Why do you need the number? Yeah, excellent, Solomon. You got it. So you will know how much you inserted it. So if you remember, for example, you inserted a chest tube and then the nurse comes running to you, oh, doctor, so-and-so, the chest tube you inserted in the morning, I think the patient pulled it and I think it's out. So can you come see it? So you will be panicking because why? Because like, you know, that tube is pulled and one of these multiple holes happen to be outside of the thoracic cavity. Patient is sucking air continuously from the atmosphere. So that is a danger. That's why I am running. Oh, really? Okay. Boom. I have to go there. The good thing, it will come out, but it's complication, right? So you run. So sometimes you will see one or two holes already outside of the chest cavity or the chest wall. They are pulled indeed. They are pulled. If that happens, your technique is poor, I will tell you, my friends. So most of the time, like if the technique was not good, it will be pulled out easily. But if you do it well, sometimes it can happen. Sometimes you never know. When the patient is transported, one of the transporters, without knowing, if they just like, pull it with a very significant force and it gets pulled, it's a painful experience with the patient, and the holes would be outside of the thoracic wall. That is dangerous. So if you know how much you have inserted it, you look into the number. It says, oh, sister, I am fine. I inserted it up to 10, size 10. So I think we're good. Okay. You say it's good, we go. If you remember the number, but sometimes we don't pay attention. Even myself, I am not going to lie to you, I have never paid attention to it, I judge by just by experience. I have never looked into the numbers, but that way it can help you, right? And there is this blue line. Do you see these two blue lines? They are not really clear here on this picture, but maybe on something else I'll try to show you. There are lines, these tubes, be it NG tube, be it chest tube, be it tracheostomy tube, they do have one single line, either a blue line, green line. Why do you think they do have that line within the tube? What is the main purpose? Radiopaque lines, excellent. So that is like, after insertion of any tube, especially chest tube, NG tube, tracheostomy tube, after you place them, central line catheters, after you introduce them, always here, it's just a must. Here in the US, it's a must. Once you introduce those, it has to be, the procedure has to be followed immediately by a chest x-ray, okay? By an x-ray, it has to be followed by an x-ray. It's a medical legal also, because you have to see it properly, whether it's properly, you are 100% sure you have done it well. You are the most experienced person, but some must. You are required to follow it with an x-ray, and those lines are like radiopaque lines, they make them visible. So this is very well demonstrated in this particular chest x-ray. You can see endotracheal tube here. Do you see it here? There is one tube here, that's endotracheal tube. And we have got intercostal drainage tube. Do you see? You see this? Follow me. Follow me. You see my cursor? Just follow me, follow me, follow me, follow me. This is a chest drainage tube. And follow me from here, from here. You see a small tube? Just follow me. It's coming from the left subclavian. It's crossing the chest and it's coming here. You follow my cross? You see? That is a central line line catheter. It's coming into the SVC or superior vena cava. So, this must be, what is it, a stable patient or critical patient? Yes, is this an ICU patient or a simple floor patient, guys? Dummy question. Critical, most probably critical patient, most probably an ICU patient. Yeah, critical patient. They may not be critical necessarily, but most probably this is an ICU patient, could be post-operative, or this is a critically sick patient who needs central line placement, chest tube, endotracheal intubation, and all that. So, that way people can challenge you. So do you think this patient is in the ICU or on the floor? You should say critical. The reason being, patient has central catheter. Not everybody does need a central line. Patient is intubated already. Patient has a chest tube. So I think most probably this guy had surgery, or patient had trauma, or patient's a medical patient. You never know. All right, all right, all right. Safe triangle of safety. So chest tube, triangle of safety. I believe you know the boundaries of the triangle of safety. One of them is the lateral edge of the pectoralis. This is a pec major, right? So the lateral edge of the pectoralis major muscle. Here you have the latissimus dorsi muscle. So the other one would be the lateral edge of the latissimus. The latissimus dorsi is here. So the lateral edge of the latissimus dorsi muscle. And the line which is drawn through the fifth intercostal space, these three lines would constitute the triangle of safety. Or in other ways, you can also follow the the posterior margin of this axilla, the posterior axillary line or mid axillary line. You can also follow the mid axillary line or posterior axillary line. So these three margins would define the triangle of safety. So if you insert a chest tube in this area, it is safe. That's why people call the triangle of safety or safe triangle. So you can see the pec major muscle here, so the lateral margin, of the PEC major. You have the latissimus dorsi. I think it's the medial border of the latissimus dorsi, and the nipple line. Nipple line is supposed to be running through a horizontal line drawn through the fifth intercostal space. So this area is called triangle of safety. It's away from important structures. So if you introduce your chest tube in this area, you are safe. That's why they call it the safe zone or triangle of safety. All right. This is another image, triangle of safety, the same thing. So you can read this slide. So if you introduce in this triangle of safety, the area of the safe triangle, you are safe. No, we don't really necessarily, when we become experienced, you don't necessarily try to define the lateral border of latissimus dorsi, medial border of latissimus dorsi, lateral border of PEC major. You don't do that. You just count the intercostal spaces. So how do you count the intercostal spaces? You come over here. So the prominent part is the angle of Louis. The angle of Louis, if you find the angle of Louis, check in yourself. There is a bump here. When you start from here, the sternal porch, you go down. There is a little bit of a bump, or like, you know, the highest point. Then that is the angle of Louis. And then you go lateral. Then that is the second intercostal space. And you count the third intercostal space, fourth intercostal space, fifth intercostal space. Why am I going to the lateral? Why didn't I count like this straight? I don't, because the intercostal space becomes narrow and narrow when you go down. So if you go down lateral, it's wider, so you can easily feel it. You go down, you can easily feel the intercostal. If you go down, you can easily feel it. And then, like, you know, if you go in through the fifth intercostal space, sometimes it's the sixth intercostal space, then you are safe to introduce your chest tube, right? So you have got to be careful, especially in both sides, going